Today we have a great talk, and it's a clinical talk, which I find really important because I think we mostly have an informatic background, not so many doctors, and to understand what we're actually doing, it's really important. And I think to understand the clinical part and having clinicians explain that to us is really, really important. So we have here Saif Afat, and he will explain a little bit about radiology, and but also give us a broader look about COVID in general and what consequences it has. So I think, the star is today is Saif. So please take the stage.
Thank you, Chiara, for the kind introduction. I am very happy to be here. When Simon contacted me, I was actually glad to join an interesting challenge and to do some kind of small lecture. My name is Saif Afat. I am a radiologist in the University Hospital of Tübingen, and I would like to talk about radiology and COVID-19. I'm not going to go deep in AI, but I'm going back to the roots, to the basics of COVID-19, what actually we can see. We're going to talk about a small introduction of COVID-19 and then typical findings of COVID-19 in CT and X-ray. Then we will talk about the role of imaging during the pandemics. We will see a couple of clinical cases. I prepared 2 cases, typical cases of COVID-19. And we will be talking about COVID-19. Is it only affecting the lungs, or does a patient with COVID-19 have other symptoms, or does it affect other organ systems? I made a small list about AI during the crisis, or it's a list for me as a radiologist, or for us as radiologists, what we think about AI. How can AI be a good opportunity to help during the pandemic? And then we will talk, everybody talking negative about the crisis. I found it nice to talk about some advantages of the crisis. So let's dive in. When I prepared the first presentation for COVID-19, it was 3 months ago. And I had the same introduction slides, a screenshot from Johns Hopkins website, but with a whole different number. The global cases, there were 7 million. And why I put this slide at the beginning, I don't want to bore you. You're all experts with the numbers. But I wanted to show that within 3 months, now we have 27 million people or cases with COVID around the globe. So it's still an important thing to look at, or an important subject to do some research or develop some AI tools about it. So the agenda, I just explained what we are going to talk about, and now we jump in. I talked about this Johns Hopkins slide, where I told you 3 months ago it was just 7 million, and now like 27 million cases around the globe. So it's still a relevant subject for research, for developing AI tools, for everything. At the beginning, I want to talk really basic, like how COVID or SARS-CoV-2 gets in the cell. It is actually pretty simple. All coronaviruses, they have an entering point, and it is an enzyme on the cell membrane. It's called angiotensin converting enzyme 2, ACE2. And this is the entry point to the cell for all coronaviruses, where they replicate, and then you have a new coronavirus affecting another cell. Why I'm telling this, why I'm explaining this is, I know it's not radiological, but I think sometimes it's helpful if you are developing something to understand the basics of the pathophysiology behind the whole thing. What we learned from the previous pandemic with SARS around 2003, this is a very famous publication that came on 2004, and it was a different coronavirus, but it was affecting ACE2, this enzyme 2. And what I wanted to show here or to explain, everybody is talking about the lungs. These receptors are not only in the pneumocytes, not only in the lung cells, but also in the intestines and other organ systems like heart, kidneys, vessels. I'm going, at the end of the presentation, I'm going to show you some examples of COVID affecting other systems in the body. And now we go to radiology in COVID-19. Radiology in COVID-19, these are articles from the press with different headlines. They are from different time points, and this is actually how the opinion about radiology and COVID-19 changed during the pandemic. At the beginning, nobody knew what's the role of radiology. And the headlines here, they are sometimes facts, sometimes only a personal opinion of some doctors, sometimes controversial. Like here, for example, here they are saying CT is not good for screening for COVID-19. And here they say CT can detect COVID-19 before PCR. And here, some personal opinion of some doctors showing the worst damage of COVID-19 in the lungs with CT images. So it was a bit controversial, and the same thing is with the papers that came out. They have different results. I'm going to show that afterwards. I have a couple of examples to understand. If you look at a publication or an article, you must actually consider different topics to understand it. Now we talk about X-ray. X-ray is our working horse in the hospital. What are the typical findings of X-ray? I think it's very important for IT informatic specialists to understand how actually it looks like. We're going to talk about X-ray here. What are the typical findings of X-ray? Before we talk about the typical findings of X-ray, here's a normal X-ray. Here, actually, a normal X-ray of a normal person, no diseases, young person. How does it look like when you have COVID? Well, that's different. There's not a very typical imaging for COVID. Is the distribution actually what makes it typical. So, and it depends on appearance of symptoms. Usually, X-ray can be negative if you take it in the beginning of the symptoms, if 4th, 5th day, or the first days when the patients have symptoms, they have an image like this, a normal X-ray image. And when they get worse, they develop bilateral. Bilateral, it means on both lungs, consolidations and ground gland opacities. They are in subpleural or peripheral. They are not central near the heart, but they are in the lungs in the peripheral area. And what we see, we radiologists, we only see consolidations, ground gland opacities, and we see the distribution at the beginning. And this is a case, this is more severe than this one, where you see it's got worse and the opacities, they went central. Studies, this is one of the first studies that showed X-ray have a lower sensitivity than PCR, which was obvious, but still not that bad actually, because 69% sensitivity, it's still good, and X-ray is available everywhere, versus 91 for PCR for the testing. So this was the X-ray part. Now we talk about CT. What are the typical findings in CT? The typical findings in CT, everybody is talking about ground glass opacities. Ground glass opacities are not specific for COVID, but the distribution, there is a specific distribution for COVID. Many viral pneumonias have ground glass opacities, but when the symptoms, when the clinical data, the data is supporting the decision that he has COVID and he has distribution bilateral in both lungs and subpleural and peripheral. So it's not central near the heart. It is outside. It is on the peripheral area of the lungs. Although here to note, it can begin on one side. So this is a thing maybe important to know. At the beginning of COVID, they can develop on one side and then they can have on both sides. Crazy paving appearance is one of the typical findings, typical findings of COVID. What is crazy paving is actually like this stone floor. So the lungs have opacities in some areas and in some areas doesn't have, and it looks like stone floor, crazy paving appearance. When this ground glass will develop after that to consolidation, when the lungs are full with edema, so they gonna have consolidations like this one, and you see it has on the there are ground glass and consolidations combinations. What the patients don't usually have, who has COVID, they have no pleural effusions and no mediastinal lymphadenopathy. These are the typical computer tomography or CT findings when somebody has COVID. And this is the first case that was described of COVID. It is a 77 years old male. It was published in Lancet. It shows the changes in the lung from day 5 to day 20 from the same patient in the same slice. And then you see the opacities were beginning in the peripheral area, they're getting worse, and then they were affecting more part of the lung. This patient died 10 days after this image, the day 20 image. So this is a typical course how the images changes. And what here to notice is it is if you are doing an AI or algorithm or you are doing a research about COVID, it's very important to consider at which time point you are actually planning to plan or design your study or design your analysis. Ground glass. Everybody worldwide is talking about ground glass. Like I said before, what is ground glass? Ground glass is not specific for COVID. It is a finding. It is something, a reaction that happens in the lungs. It can be caused by different pathologies, different diseases causes that, and how it happens. What I aim with this slide is you see how it looks on the CT. This is a normal lung cell, a pneumocyte, and this is how it looks. It looks normal. And when we have an acute infection, then you see it's still looking normal at the beginning. And this is actually what's happening with COVID. This is why you cannot see in the CT at the first days no findings. And at day 5 to 8, you see the changes. And what we see, these white opacities or these white changes on the image are edema, because here the immune system will activate and the cell will be filled with edema, and this is actually what we see and what we see white on the lung. And the more it gets filled, then it will change to consolidation after a while. I noticed maybe for some a little bit boring, but it is very important sometimes to understand the link between the pathophysiology and the image, why we are seeing it white, so we can understand it is the edema what we are seeing, and not very specific, not the virus we are seeing. CT versus X-ray. what are, from our clinical routine, what are the advantages, disadvantages of both systems? During the pandemic, CT, we noticed CT have a higher sensitivity than X-ray, and you can see it very good on this image. This is the same patient. This is CT image on the right side, and on the left side is a chest X-ray from the same patient on the same day. In the chest X-ray, you can see it's a normal chest X-ray. Every radiologist will write a normal report for this chest X-ray. But when the patient has a CT, then you see these mild changes in the lung, in the lower part of the right lung. They were seen in the CT, but here you cannot see them. So this is what we mean with sensitivity, that CT is more sensitive than X-ray, and it can also detect COVID in the early phase than X-ray. It can detect other relevant findings, of course. It is pulmonary artery embolism. Other findings you can detect better. The disadvantages or the limitations are it is not available everywhere. It's high costs. It costs more than X-ray, and it has a higher radiation exposure. The big advantage for clinical use of X-ray, and this is why somebody may ask why we don't only use CT. X-ray is much more flexible than CT. CT is a fixed machine usually, and X-ray, we have many mobile devices, for example, here in Tübingen, and you can move it to the emergency room, you can move it to the ICU, and you can take images there. But with a lower sensitivity though. Now we can see two cases, typical course, typical patient history, how a COVID-19 case comes in. This is a 62 years old male. He had pain in the lungs, dry cough, fever at the end of February. That was the time where COVID started in Germany, and he was tested for influenza and RSV negative. He had a X-ray in a radiology practice, and then he was tested 2 days after that positive for COVID, and he was transferred to the hospital. And you see, this is the initial imaging. This is the initial X-ray image of the patient in the radiology practice, and it looks almost normal. And days after that, you see this is time point 2. This image was taken in the hospital. You see he started developing some opacities on both sides in the peripheral area more than the central area. And the patient had a CT2, and here we can see, or you can, come back. Here you can see the bilateral, I think we're going to go back. This is the wrong case. This is the right case, I'm sorry. Then you can see the bilateral ground glass opacities. They are in the peripheral area and affecting all lung lobes. Another case, it's a more severe case, 56 years old male. He, after a business trip in Scandinavia, he was found precoleptic in his apartment. He was transferred with the ambulance to a small hospital. He was tested positive for COVID-19, and the situation from there got worse. So he he had an intubation 3 days after admission. And after that, he was transferred to a university hospital, to our hospital for ECMO therapy. For you, if you don't know what's an ECMO therapy is an extracorporeal technique or a support system. If somebody have a problem with oxygenating the blood, so it will problems with the heart or with the lungs, so the blood that deoxygenated will be oxygenated in the device, and the device will give it back oxygenated. And this technique was mostly used in very severe cases of COVID-19 and positioning therapy. It's a therapy that's intensive care unit where they change the position during the day of the patient to change the distribution of the edema. This patient had a CT. It was before he came to us. It was a CT. You see consolidations. I'm going to pose it here. You see consolidations. You see bilateral ground glass, no pleural effusion. And after that, he had, before, this is where he got the intubation, and you can see the course, the timeline of the patient. He got worse at this point. So he got transferred to the university hospital, to our hospital, where here you can see he had the ECMO therapy, where you see this cannula, this is the ECMO therapy. And you see with the timeline, at least the right lung got better. And he survived it, and the case actually he did it helped him a lot with this therapy. So these two cases, they were typical cases of COVID-19. About the first one was light one, and this one is a severe case. Now we talk about recommendations, statements of different authorities. This is the up-to-date statement or recommendation of Robert Koch Institute. Robert Koch Institute is a German federal government agency and a research institute too. It is responsible for disease control and prevention, and it was giving the official recommendation during the pandemic. Till now, it is the official recommendation. And you see, I'm sorry for that, it is in German. I didn't find an English version of this. You see, they stated that imaging or X-ray has 50 to 60% sensitivity of detecting COVID-19, and CT has 85% sensitivity to detect COVID-19. So it is relevant that research or AI tools should be developed for COVID-19 and for imaging. I said before I'm going to show some papers about sensitivity, CT versus PCR, and how the discrepancies between the results. Here's one of the earliest papers. They had a large cohorts from China, over 1,000 cases, and you see the sensitivity of CT is here 88%, and the sensitivity of PCR is 59%. Another paper, another publication, it's a review where they compared CT to PCR, and you see the range is different too. There are some publications, they stated 44% sensitivity for CT, other stated 98% sensitivity for CT, and the same, there's ranges too for PCR. What I'm trying to say with this, with these two examples is, when you look at publications or when you design your study, you must really think about how to design it and what you want to answer exactly, and what is your cohort, which images you are going to include, inclusion criteria. They play a huge role in this, and they cause these differences in the studies. Conclusion from this review that CT has a limited sensitivity and it should be used as an additional diagnostic tool, which is actually a reasonable conclusion. If we look at official recommendations of two very important, in Germany, very important groups, this first recommendation is from the working group Thorax of the German Röntgen Society. They said imaging should be not the primary tool for the diagnosis or screening. Negative CT does not mean the patient doesn't have COVID-19. They see the strength of CT or the important task for CT in other parts of the diagnostic for detection of complications, supporting the clinical assessment for the prognosis or follow-ups for the patient, and a big role in times where the crisis at its peak is the role for the triage for the patient. The same thing was stated by the Fleischner, or recommended by the Fleischner Society. Fleischner Society is an international multidisciplinary medical society for thoracic imaging. And this is the same thing what they recommended, that the use of CT at peak times because CT reports are faster than PCR. A number to imagine how fast a CT report is compared to PCR. A group of radiologists in Aachen, in Germany, they took this theory and they tested it, and they found out on average it takes 9 minutes to get a CT results of the thorax with patients with COVID-19 patients, and it takes 491 minutes for PCR results. So it's very relevant. The imaging or CT is very relevant for triage or for critical times of crisis or upcoming crisis. This is an interesting thing, maybe for developing algorithms. The German Röntgen Society and the American Society is called RSNA, and this is from the Netherlands. They developed scoring systems. It looks at the first sight complicated, but it's pretty simple. It is, for example, in the German Röntgen Society, it is 1 to 4, and 1 is no suspicion of COVID-19. The findings, the CT has no suspicion, and 4 is typical COVID changes. Why it is actually important to have a scoring system? It is important because if you develop AI systems that can group the patients in these categories, that could be helpful in the clinical routine. So you can take a look at the most important cases at the beginning and look at the less important cases at the end. Which system to use is actually, I think, in my opinion, is not that important. The German scoring system and the American scoring system are almost identical. The only thing is to think about to take a with 5 points system or a 4 points system. The 0.6 here, it is a proven PCR, so it can be actually left out. You don't even need a CT for this one. It could be interesting if you're developing AI tools. I talked before that about I showed you the life cycle of the virus, and it has an entering point using the SEE2 enzymes on the cell membrane, and I'm showing you now a couple of publications, interesting publications. This one is published in Radiology, and it's showing 47% of the patients had an abnormality in their acute neuroimaging. So it is relevant. Actually, some changes are happening in the brain. What is happening, nobody knows at the moment. There are studies now going on to find out what's happening, but there is something. There's some link between COVID and the brain. The same thing was found with the intestines. In this study, they found imaging findings. Patient tested positive for COVID, and it was 31% of them had changes in the abdomen, in the intestines. Cardiovascular system is affected by this too, and for this here, for example, you see basilar artery thrombosis in the head, and this is after recanalization, and here are thrombosis or embolia in the lungs. These are things somehow linked or connected to COVID too. An interesting study is an autopsy study that showed from the 7 of 12 patients who got an autopsy had a deep vein thrombosis, and before that it wasn't suspected for thrombosis. So what I'm trying to show with these publications or these case reports, is COVID. We shouldn't only think of COVID as COVID-19 only in the lungs, but we should also think further than that, and it is proven that it's affecting other organ systems in the body, not only the lungs. Now, I think this is an important slide for you. What radiologists think of AI in the crisis or in the pandemic and times of COVID-19. The main goal, what, in my opinion, very important for AI developers is, I think AI can support radiologists to have a faster, more efficient diagnostics. I think COVID-19 can help with automatic detection for the findings, automatic classifications, like I showed you before. For example, if you have 100 cases and you have an AI tool that can rank these cases and show you the most urgent one at the beginning on your work list and the less urgent one at the end, so you can begin to do the reporting for the most important ones at the beginning. I think AI can help with the prediction of severe courses or prediction of outcome for the patients, can improve the accuracy of radiologists, like an assistance system that will help. There are some tools that can show us some annotations, like look at this area, take a second look at this or that. I think it will help with the development for infrastructure, for studies and data integration, and I think AI will play a big role with preparation of the data for secondary analysis or for linking platforms, like if you are linking a radiology platform with a virology platform, so more information can be prepared. What are the advantages of the crisis? I found it a good point to talk about. We talked. Everybody's talking about disadvantages, about the negative of the crisis, but I think there are some positives of the crisis. We saw research funding got much quicker in terms of the pandemic. I think the organizers of this challenge will approve that too. I think Simon maybe will tell us later if he thinks that this challenge will be doable in normal times and not in the crisis, like to do it so quick and get such a good collaboration and having a multi-center cooperation. This is, I think, our advantages. These are advantages of the crisis, and I think we learned a lot from the crisis, how we can work faster, more efficient, and develop AI tools, develop study designs more better. So my take-home messages are very simple. We saw the typical findings of COVID-19. I think if you are an IT developer, you don't have to know every little thing about the disease, but if you know the typical things, the typical changes of the disease, that would be very helpful. I think that will help you understand the disease much better. We talked about the use of imaging in times of COVID-19, and I think we talked about it. What are the recommendation of the official agencies? Then we talked about extrapulmonary manifestations, where we can find COVID in other organ systems, but not only the lungs. And I hope my points about how AI can help support during the crisis can help you like a small inspiration about developing what is the goal of developing AI algorithms. And we talked about the positive aspects of the pandemic. That is not only negative, but there are positive parts or positive things happened actually during the pandemic. Thank you very much. I hope you liked it.
Yeah, thank you very much, Saif. Very great talk. I had the opportunity to sneak peek a little bit yesterday. I found it very fascinating and a lot of good ideas and your approach on thinking how actually the crisis helped us. I think that's a good question, and you directed the question towards me. So I want to answer it as well. You
please.
Said that would anything like the Covid-19 challenge that we're running right now have been possible without the crisis? And I think no. One is a personal reason. I can tell from my perspective because I didn't go to the clinic because we shut down the operating rooms and they have had over 400 overhours. So I had to take my time off. So I had time. I don't know if others also had a similar experience, maybe with, we call it Kurzarbeit in Germany. So you had to work less for a little bit less compensation as a salary. So people had a little bit more free time, or they were on home office and were more flexible in how they would dedicate their time. So, but of course, the COVID-19 challenge wouldn't be possible without the sponsors. In the first place, AWS, so Amazon Web Services, that gave us $30,000 in credits to run the platform because the training of the data on the private data set is quite expensive. So without their support, it wouldn't have been possible. And also with BrainLab joining in as a sponsor for the awards, that's also pretty great. So that was my answer to that. So I think that the pandemic also has opportunity, and we grasped it somehow, and we had the opportunity to run something like this, a very fascinating challenge, which is, for me at least, very inspiring, and I learned a lot. But I have a question as well. I noted to put down some questions. So you talked about the deep vein thrombosis and that dissected people that died from COVID-19 showed in a high percentage thrombosis of the veins. So my question to you as a radiologist, can you also see that in the thoracic X-rays in terms of pulmonary thrombosis or embolism? Does that happen?
You cannot, in X-ray, you cannot see it. It's a very good question.
We cannot hear you. You're muted. Safe? You're muted.
Now? Hi? Can you hear me? Hello?
Sorry, yes, I cannot hear you. Can anyone else hear him?
Safe, I can hear you.
Yeah, you can, right?
Yes. It's only Simon.
Simon can't hear me.
Kiara, can you hear? Or maybe it's my problem.
Yeah, I can hear you and Saif, both of you.
Okay.
Me too.
I just shut up. I'll try to solve my problem.
No problem. No, thank you for the question. It is an important question. This is why I tried to explain the basics about the imaging. In X-ray, you cannot see the embolism in the pulmonary artery. What you can see indirect signs of this. And even in CT, if you perform a CT on a patient with no contrast agent, you wouldn't see the embolisms. And it is actually, it's very interesting. During the pandemic, we noticed like severe patients, severe cases. They developed embolisms in the liver, in the pulmonary arteries, and while we are noticing there's some contact to this, or because they are very sick patients, then the publications started to come, the case reports that started to come that the cells, this enzyme is also in the vessels. But in an X-ray, you cannot see embolism directly. Any other questions?
Yes, I do have a question. So you were comparing the time that it's needed a CT, so 9 minutes in comparison with the PRC.
Yeah, that's right.
And the pace, like I think, yeah, hours or sometimes days. But I think this, of course, when you stay in the city machine, it's quite fast. But I think the organization around it is not so super fast. So during the pandemics, really, when you have a lot of patients coming in, it's really so efficient to do so, and then you need to clean everything because you're not sure if the patient was COVID positive or not. So how did you organize it well so that the organization of the hospital was optimal for that case?
Chiara, this is a very, very good question. I must admit, but it is not only Tübingen, the university hospital, every university hospital has didn't know actually how to deal with this. And the hygiene rules, they were different from university to university hospital. And what we did at the beginning, this is why actually this is a limitation of CT. You don't have, for example, we have in Tübingen 4 CTs and 10 or 15 X-ray devices. So this is a huge difference. It is more available. X-ray is more available. It's they are both actually easy to use and easy to clean. At the beginning of the pandemic, we were blocking the machines 1 hour till we start new examine and examine new patient. But after our hygiene department, they changed it to wet cleaning and waiting for 5 minutes. So it is actually okay. CT is or imaging is much faster, and I see the opportunity of imaging is really in the triage of patients. If you have a load of patients like you described, they are coming in your ER and you tested them, but you need to know it. You need to isolate them or not. And if you pick 80% of them and provide a good statement from the CT, you can. It will be actually great and helpful for the emergency department. So the load will be less on them, so they can send their patients. You go home, you go to the station, you go to ICU. So it's a very helpful device, of course.
Thank you very much.
I think
there's another question raised by Connor in the events community text channel. I don't know if he has problem or she has problem to ask the question directly. He says, I have a question about the potential cardiovascular effects. Apart from the CT records of patients, are you collecting cardiac MRI records simultaneously? Is it possible to further evaluate the effects of COVID-19 on respiratory and cardiac systems for achieving a better analysis? And he's thankful for the presentation.
Okay, that's a great question, actually. Apart from the records of the patients, are you collecting cardiac MR records? This is a very good question. In Tübingen, we are a cardiac center, and we would like to examine this, actually. What we noticed, or what have been noticed, there are some changes in the heart muscles and professional athletes who had COVID. They had a less power after that, or they weren't back on their level after COVID. And some of them showed in MRI, in the cardiac MRI, some changes in the heart muscle. We in Tübingen, we were defensive with this. We are starting to see, now we have some studies starting to see what damages on long term are caused by COVID. But we didn't do a CT and at the same time an MRI. We didn't do that. we didn't have the capacities during the pandemic to do that.
Okay, thank you very much. Are there any other questions? Well, obviously not. Safe. Thank you a lot, and greetings to Tübingen. You have to come, drop by to Munich, and
I will indeed. I will indeed. And if any questions or any further comments, you can email it to me, or I can write my email in the general channel. Please feel free to contact me if you have any kind of questions.
Yes, his username is Saif Afat, and I think you can contact him directly on Discord as well.
All this.
So thank you very much.
Thank you for the invitation. Have a nice evening.
Yeah, bye-bye.
Bye-bye.
Bye-bye. Thank you, Saif. Bye.